Training Center, and on behalf of the Training Center and of the Department of Health and Mental Hygiene, I'd like to welcome you to this month's presentation on men's health, addressing its physical, social, and economic determinants. Before we begin today's presentation, I'd like to invite you to visit our website to view our other upcoming trainings, which include our core competency training series with Dr. Carolyn Fowler, and our assessment training, community assessment training with Dr. Cubb and Dr. Fowler. We also have some new trainings coming up, so keep your eye out for a training on using social networking to advance public health and environmental health complaint investigation. Also, be sure to join us for next month's Grand Rounds presentation on June 17th with Dr. Cliff Mitchell and Anna Reckland from DHMH for their presentation on using health impact assessment in transportation planning. For those watching online, we invite you to email questions for the presenters at any time during this webcast to our email address at maphtc, which stands for Mid-Atlantic Public Health Training Center, at jhsph.edu, Johns Hopkins School of Public Health. And if you're watching this webcast with a group, we ask that you let us know that by email so we can let our federal funders know that you joined us. And you have our email address. And with that, I'd like to go ahead and introduce our first speaker today, Dr. Jean Ford. Dr. Jean Ford completed his undergraduate studies at Columbia College and received his MD degree from the Columbia College of Physicians and Surgeons. He completed training in internal medicine at Harlem Hospital Center and in pulmonary medicine at the Columbia Presbyterian Medical Center. Dr. Ford joined the faculty at Harlem Hospital and the Columbia College of Physicians and Surgeons and received additional training in molecular epidemiology of lung cancer through an NCI-funded Clinical Investigator Award. In 1996, he became the chief of the Division of Pulmonary and Critical Care Medicine at Harlem Hospital, a position that he held until July 2002, when he moved to Baltimore. During his last 7 years at Harlem Hospital, he also served as principal investigator of the New York Center of the National Heart, Lung, and Blood Institute's Asthma Clinical Research Network. Currently, Dr. Ford serves as an associate professor in the departments of epidemiology, oncology, and medicine at Johns Hopkins. He also directs the Health Disparities Program within the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. This multidisciplinary program aims to develop evidence on determinants of disparities in cancer status, access, and quality of care. Dr. Ford recently completed a systematic review on barriers to participation of underrepresented populations in cancer-related trials. He currently serves as principal investigator for a large population-based randomized controlled trial to evaluate the efficacy of a nurse-led team of community health navigators to promote adherence to screening and treatment for breast, cervix, colon, and prostate cancer among African American older adults. With that, I'll hand it over to Dr. Ford.
Thank you, Molly, and good afternoon. The title of the talk is on determinants of men's health, although I will touch on this somewhat lightly in that our second speaker, Dr. Schell, will be talking in more depth about social determinants and economic determinants and so forth, especially trying to get into the minds of men. What I will be doing today is to provide some perspective from an epidemiologic point of view of where those disparities are comparing men to women. Discuss briefly what the risk factors are for men, that is the non-modifiable factors as well as the modifiable risk factors. We will take this opportunity to briefly speak to some of our ongoing work in the community about colorectal cancer, in particular, colorectal cancer screening project, and we will highlight recommended screening approaches, and we will end with some reflections about implications for public health programs. gender is a major determinant of health. It affects the lifespan. It affects the patterns of disease from the point of view of the age of onset of chronic diseases, which may or may not be fatal, the age of death. It affects mortality rates. The gender disparities have existed for quite some time. However, they're not simply biologically determined. In fact, if one looks historically, the level of gender disparities have changed across the centuries, and in fact, they have not been as bad as they look, and sometimes they have been more favorable to men. Nonetheless, in the current context, we know that there have been technological advances, and yet disparities persist. They may be related to gender roles and norms, to health beliefs and behaviors, and there is, in fact, a hypothesis that biological differences contribute, and certainly with two X chromosomes versus an X and a Y, the biological makeup is different, especially in terms of exposure to hormones. But whether that is one of the principal determinants of gender differences in health status, that is a subject of intense debate, and one that is being studied actively at this time. We will not spend much time to talk about that. Clearly, the cultural context is important in that those gender differences are going to express themselves differently across different cultures. So we will see the gaps vary across such contexts, and I believe that Dr. Schell will speak more to that later. And clearly, we know about the existence of socioeconomic and racial disparities here in the United States, and probably and certainly globally, and there is an interaction among these factors and gender as determinants of health status. So this slide shows how it is that gender and race differences in health status, particularly in life expectancy, have fared over the period of 1975 to 2002 in the United States. As you see, this is what has happened during this time in terms of the female to male difference in life expectancy. It has gone down dramatically since 1975 that you see here. And it's generally thought that this actually began back around 1965, especially since the first Surgeon General's report, where one of the major modifiable risk factors was addressed because the problem of smoking was highlighted. And here we are, looking at pretty much the same data, but stratified by gender. And in terms of life expectancy, white females have the highest, and then black males, although here, converging here with white males, and black males consistently show a very significant gap in terms of life expectancy. And a few years ago, a colleague of mine in Harlem, that's where I was for so many years, he did a study which was published in the New England Journal of Medicine. Cook, McCord, and Allen and Dr. Freeman published that a man born in Harlem was more likely to die by the age of 5 than one born in Bangladesh as of the early 1990s. So, we're talking about men in the United States. It's a population of approximately 150 million people. Basically, in terms of what they report in major national surveys, I've referenced them at the bottom of the slide here, 12% report that they're in fair or poor health. Another 12% report limitation in usual activities due to a chronic health condition. And in terms of health risk factors, this is the distribution from Health United States 2008. 24% smoke, and we know that there are racial disparities in terms of the prevalence of smoking. The prevalence for African Americans in general tends to be higher, especially in urban centers such as in Baltimore where we are here. The prevalence of overweight in the total male population is about 72%. And in terms of hypertension, it's 31%, and this is all for adult males. Yet these individuals, and these are aggregate data for the entire population, there were nearly 370 million office-based physician visits in 2008, which is very interesting because it potentially indicates opportunities for intervention in the context of public health intervention in the context of primary care visits or other types of visits. 18% of the population, the male population, is under 65. Under 65 does not have health insurance coverage, and again, that varies by a number of different factors, including socioeconomic status and race, and 20% of adults do not have a usual source of care. Quickly, a few slides about the leading causes of death in males. As you see here, the usual suspects: heart disease and cancer. Unintentional injuries is quite significant, stroke, and so forth, and you can go through the list. This is for males in the United States overall. However, that list is slightly different when one looks at, for example, white males. This is what the distribution is. Since there are more white males than other groups, then that's pretty much going to drive the national numbers overall. This is the distribution. For black males, the list is a little bit different. Suggesting, and so on, when you look at Hispanic males, suggesting that, one, we tend to look at aggregate numbers, but in terms of prevention efforts, we really need to look at different populations. The risk factors do vary, and also the disease profiles do vary overall. There are some non-modifiable risk factors. Being male is usually not a modifiable risk factor. The family history, one cannot change that usually. Age and genetic factors, those are non-modifiable risk factors. On the other hand, there are amazing public health opportunities when one thinks about men's health in the context of what is it that we can do to actually change what we're seeing beyond major social changes which we know could potentially affect public health. And here we're talking about health-related behaviors. There are sociocultural influences. Men are more likely to engage in a number of behaviors that increase risk for disease, injury, and death. We know about alcohol consumption being a major risk factor in that group, including binge drinking, and also the use of illicit drugs. And compared to women, men are less likely to use to access routine health care. And all of these factors potentially affect men's health. One of the emerging areas of research that we hope will provide more clarity as to what are some of the determinants of men's health is social networks and support systems. And I hope that Dr. Schell will be able to elaborate on this a little bit more. This is just an overview of some of the factors that we see. Now, talking specifically about some of the risk factors, you see tobacco use tracks very closely with lung cancer mortality. This is per capita consumption in the US of tobacco, and lung cancer mortality in blue here follows it very closely. And the epidemic started later in women as they took up smoking later on a population basis. this slide is showing the trends in cigarette consumption for men and for women. The gap persists, and so there are opportunities there also. We don't talk much about male obesity. The prevalence of obesity is greater in men, in women than in men. Nonetheless, as the entire U.S. population becomes more obese, as you see dramatically on this slide, so do men. I'm not showing you the specific data for men, but that is the case. There is emerging understanding of some of the changes that are happening to men in the Middle Ages, which may relate to a large extent to some of the morbidities that they experience. And there is what has been referred to as the aging male syndrome in terms of feeling fat and gaining weight, and some of us are in that category learning about this firsthand. Problem sleeping, decreased libido, feeling irritable or angry, erection problems. I guess we can't escape that with the media. Nervousness, problems with memory and concentration, and so forth. Depression is highly prevalent among men and is often undetected. So clearly, there are a number of different factors that we can think about in trying to differentiate between men and women in terms of their prevalent risk factors. And if we want to affect men's health, it's important to think about those. I'm going to talk a little bit about cancer because that's an area where I focus mostly on a day-to-day basis. And this is here the distribution of cancer deaths, about 365,000 cancer deaths per year. And as one sees the top three causes of cancer deaths, lung, prostate, and colorectal cancer. Men have more, they die more from cancer than women. And looking at men across racial and ethnic groups, there are clear disparities in that for both men and women, the rates vary. The age-adjusted mortality rates vary, with African Americans having the highest cancer death rates of any group. But within each of these groups, whites, African American, and so forth and so on, men have more cancer than women. And we believe it is directly related to the risk factors that they're exposed to. Now, there are different ways to prevent cancer. There is, you could do primary prevention, which is to prevent the exposure, or in certain cancers, one of the ways to prevent it is to do secondary prevention, which is early detection. And in the case of colorectal cancer, here in the state of Maryland, we're blessed with major public health programs that are attempting to reduce the burden of colorectal cancer through screening. And there's a major success story there statewide. And one of the screening modalities is colonoscopy. Well, there are two of them that I'll talk about briefly as part of our research, which is sigmoidoscopy, which goes down here to the descending colon, whereas colonoscopy goes all the way here to the very beginning of the colon. So it's possible to directly visualize the entire colon, although there are other modalities of screening, especially here, fetal occult blood testing that you see here. We are participating in a national demonstration of patient navigation or health coordination strategy to promote participation in cancer screening and treatment among minority older adults, although in Baltimore we're focusing strictly on African Americans. I'm going to show you a little bit of our experience in this particular project. This is the tool that we use to recruit participants, and as you see, it's culturally targeted to African American older adults, and we seek to enroll individuals who are age 65 and older, have Medicare Parts A and B, not currently diagnosed with cancer, in a screening trial. And the answer questionnaire, and this basically describes the demographics of the group that we're looking at, that is predominantly female. And interestingly, even through a population-based recruitment strategy, we find it more difficult to recruit males than females, even when we go door to door and recruit through the homes. 75% here are females, and when we recruit from adult daycare centers and senior homes, and so adult daycare centers, the disparity is even more pronounced. These are characteristics of that population. And here, what we find is a major disparity in terms of participation in colorectal screening. For males, they are about 38% less likely than females to report that they've had a colorectal endoscopy within the previous 10 years. And as you see here, this is a list of additional factors that are associated with colorectal screening in the entire population, in the entire study population, about 1,000 individuals. These are the factors in the 267 men who were eligible for this analysis. The major factors that we saw, the men who had less education were about 3 times less likely to have been screened than those, that is, the men with more than a high school education were about 3 times more likely to have been screened than those with less than a high school education. And men with comorbid conditions were twice as likely to have been screened. Now, this particular relationship, it varies by study, but this is what we saw in Baltimore City. Interestingly, when we look at some of the factors in women, but with a much larger sample size, we are seeing that this is a distribution of factors. Here, education is also important than in women, in that those who have less than a high school education are less likely, about 40% less likely to have been screened. What we also observed is that in women, literacy is an important predictor of screening. We're not showing it here, whereas for men it didn't really come up. It may be that the numbers are small. So we know that the screening prevalence and other factors may in fact vary by gender, and it's really important to look at those stratified by gender because the determinants are going to vary across those groups. I would like to spend the remainder of the time to talk about evidence-based interventions that are available to improve men's health status. And in doing so, I would focus primarily or almost exclusively on the recommendations of the U.S. Preventive Services Task Force. That is, what is it that one needs to do, or what is it that men need to do in order to maintain their health and prevent disease? And these are evidence-based recommendations after reviewing the world's literature, coming with what is it that's been established in the literature. I realize that there are a number of factors that are important, or interventions that may in fact be efficacious within specific populations, but they haven't necessarily met the level of strength as evidence that they would make it onto that list. So I'm just representing those recommendations of the U.S. Preventive Services Task Force. First, get recommended screening tests, being tobacco-free, being physically active, eating a healthy diet, staying at a healthy weight, taking preventive medicines if needed. I mean, these are, it sounds like it's a no-brainer, but this has been studied, and that is what's established in the literature. What are the screening tests that men should use? They should calculate the BMI. There's a BMI calculator that's available online, and for those who don't have access, it would be something that could be provided in the context of a primary care intervention or in the context of community-based programs. The cholesterol level should be checked regularly beginning at age 35. And individuals who have certain conditions, such as diabetes, hypertension, a family history of heart disease, or who are smokers, are advised to actually ask their providers whether or not they should be screened, even below the age of 35. The blood pressure should be checked at least every 2 years. Testing for colorectal cancer should start around age 50, although there is some discussion currently as to whether this guideline should be revised because of the major disparities in colorectal cancer in African Americans and the possibility that, in fact, it may be appropriate, given where the evidence is going, to begin screening earlier. However, it is not at the level of the guidelines of the U.S. Preventive Services Task Force at this time. Some individuals may need to be screened earlier if there is a family history. So when screening begins depends on the risk level. I have included here prostate cancer screening in the context of informed decision making, because we all know that there is a controversy at this time about whether or not there are benefits to prostate cancer screening. So that should be done in the context of informed decision making. If an individual has hypertension or high cholesterol, should be tested for diabetes. Should ask the person if they fell down, sad, or hopeless, screen for depression. It is highly prevalent in men. Encourage men to talk to clinicians about being screened for depression, whether they should be tested for sexually transmitted disease, infections. Once in a lifetime, that is between age 65 and 75, there should be a screening for an abdominal aortic aneurysm for individuals who have smoked 100 or more cigarettes in their lifetime, because there are increased risk for what we call the AAA, and which can have fatal complications. And also encourage men to use a checklist when they go to their doctor's visit with their medications and other relevant health information. These are the conditions under which people should be tested for HIV, have had sex with men, a number of different risk factors that are listed here. So these are the steps, and it pretty much recapitulates what we had talked about earlier in terms of how it is that men can stay healthy. And sometimes it's possible to take medicines to maintain health. Aspirin may be useful in some individuals beginning after the age of 45. Sometimes if they're younger and have certain conditions that increase their risk of coronary artery disease. And adult immunizations should be considered every year starting at the age of 50, and perhaps younger for men who have certain chronic conditions or who are immunocompromised. The pneumonia vaccine should be administered once after the 65th birthday. And I'm going to close by just reminding us that interventions need to be culturally targeted, because all this information is great, but the populations vary. And I will just use the example of what we use in our prostate screening program targeted to African American men. In other words, we use the faces of people with whom they're likely to be familiar in Baltimore City. And in the end, I think that it is people faces with whom people are familiar that will influence their behavior. But by the same token, I think that there's a lot to be learned about which way to go to improve men's health. And I just want to close with the following summary, that gender-related health disparities have many causes. The distribution of risk factors for disease varies by gender. Some risk factors are not modifiable, but some are. Evidence-based interventions are available, which can be implemented in primary care or in the community. And delivery of such interventions should be culturally targeted, and I would strongly encourage a participatory approach, getting men involved in designing program, in planning the interventions, because I suspect that this kind of buy-in is necessary for the success of programs. Thank you.
Thank you very much, Dr. Ford. I'd like to just remind everybody who's watching online that you can email in your questions for either of our presenters at any time to our email address, which is MAPHTC, stands for Mid-Atlantic Public Health Training Center, at jhsph.edu for Johns Hopkins School of Public Health. And with that, I'd like to go ahead and introduce our second presenter, Dr. Schell. Dr. Schell earned his MD from Howard University in Washington, D.C., where he also completed his internal medicine internship, general surgery internship, and residency training in community health and family practice. He then completed a fellowship in primary care sports medicine and adult fitness at Marshall University. Dr. Schell was a leader in sports medicine and served as a team physician with the USA Basketball and the U.S. Olympic Training Centers, among others. Dr. Schell also served on the State of Maryland Governor's Commission for Responsible Fatherhood and has lectured and trained groups nationally on men's health and well-being issues. For each of the past 11 years, Dr. Schell has participated in overseas medical missions in African or South American countries and the Caribbean, providing direct medical care, spiritual, and life skills direction to boys, men, and families. From 1999 to 2006, Dr. Schell served as the medical director and program manager of Adams House, providing medical, educational, psychological, spiritual, financial, parental, relational, social, occupational, and legal direction and case management to fathers and men of all ages. Dr. Schell's passion is to help children, youth, young adults, and adults understand who they are, how they feel, how they are perceived, and what has influenced their lives and health, and how their health may influence their futures. With a greater understanding of these truths, Dr. Schell believes that individuals may then develop a proactive purpose, plan, and path for their health and well-being. Dr. Schell is currently the health officer for Prince George's County in Maryland. With that, I'll present Dr. Schell.
Good morning, everyone. Good afternoon. Thank you for being here today. We're going to talk a little bit about men's health from what I call the social medicine perspective. Thanks, Dr. Ford, for going over our basic and most important medical issues with screening, but most of the time it's difficult to understand how do you communicate with a man to let him know that he even needs health care. So we're going to look at a few slides today. I'm from Prince George's County, Maryland. I have the unique opportunity to be one of the health officers representing one of the counties from our great state of Maryland. We're just outside of the district. Prince George's County, we have two men's health centers, one in Landover and one in Suitland, both inside the Beltway. You know, Adlai Stevenson had a quote in an essay that he wrote about how do you graciously concede when you've lost an election. And he quoted President Lincoln. When asked once how he felt after an unsuccessful election, Lincoln reportedly said he felt like a little boy who had stubbed his toe in the dark, too old to cry, but too hurt to laugh. And when I think about men and I think about a man's ability to express himself, to think about why President Lincoln would describe the failure or the loss of an election like stubbing his toe in the dark, but he didn't feel like he could cry, but he didn't also feel like he could scream. And I think from a man's perspective, we often try to figure out how do we express ourselves, what do we say, when do we complain, when do we not complain, when do we show that we're weak, when do we show that we've been penetrated, when are we vulnerable? And I think all of these things have something to do with how we express ourselves in life. So when you see this gentleman, Tarzan, flying through the air, when are you going to talk to Tarzan about his health care? When are you going to get him to come down long enough from this exhilarating ride that he's taking to talk about his general preventative care and well-being? Because Tarzan is very unlikely to sit down and focus on his health. And comments that I make are generalizing. All men are different. Not all men are the same. But when you think about when do you need to see a doctor? As a family doc, I'm a family physician. I've been in practice for many years. I've been in public health for a long time. We try to think about what are the opportunities that we have to discuss someone's health with them. You know, when do you get them thinking about the need to interface with the healthcare professional, come into the healthcare setting when it's not an emergency? You know, when does a guy need to see a doctor? When we're going to fill him up with medications? Is it only when you need a treatment? Is it only when you're ill? Is it only when you need routine healthcare screening? When is a guy supposed to come in to see a medical provider? And then when is a guy supposed to stop? All of us are busy. No matter what you're doing in your life, life is just passing you at a rapid rate. And when do you get off the conveyor belt of life to take the time to go in for a general routine screening that's going to make you stop this ride? Because a lot of us guys, and women too, but we're talking about men today, take life at this pace. You're moving, everything's running quickly, and when do you stop to say, you know what? I'm just going to take some time to check on myself. You know, when do you stop to think about your food choices? We want someone to eat, of course, this healthy diet with as many different colors as possible, with fresh fruits and fresh vegetables. We know that's what we want to do. And then when do we have the opportunity to do what LL Cool J has done in his 40s, I believe. I believe he's in his 40s, to look like this? Do we have the time to spend enough time in the gym to get enough aerobic, anaerobic? Do we have the time to focus on our bodies so that in our 40s we'll be lean with the appropriate BMI and a body fat that's probably down around 10% somewhere? It would be nice for all of us. No man would say that he does not want his body to look like this. Most of the guys I know, at least, would say that they want to be lean. But what does it mean if you're defining a healthy man? What does that entail? Well, from my perspective as a public health official and also as a primary care doc, when I look at a healthy man, we've defined it for years with health, his emotions, his social well-being, and his values. And my thesis has been for many years that unless in the healthcare arena we are ready to look at each of these different components of a man when he is before you, you will fail to realize what really constitutes that individual being healthy. We can look at their health alone, but taking their health out of context from emotional and social issues and their values will not arrive at a healthy individual. We may think we have a healthy individual, but I don't think we'll really be able to achieve it. Race, ethnicity, and healthcare. We'll look at it just a little bit. You know, we look at this issue of fewer than 8% of African American men having graduated from college, 17% of whites, and 35% of Asians. Less than 45% of white African American and Hispanic male high school graduates between 16 and 24 are enrolled in college compared to 68% of young Asian high school graduates, according to the Kaiser Family Foundation. These issues will have an impact on a man's ability to access health care. Unemployment rate for African American men twice as high as white Hispanics and Asian men. 20% of African American men live in poverty compared to 18, 12, and 10%. These factors will definitely have an influence on an individual's ability to access care, their knowledge of health care, and their predisposition to even engage the healthcare community. Also, according to the Kaiser Family Foundation, and we all know health insurance is important. If you don't have health insurance, you're going to be more likely to delay care, you're not going to seek routine care, you're not going to fill your prescriptions, and you're going to be diagnosed at a later stage than if you had a usual source of care. So our discussions around the country for healthcare reform how do we allow individuals to get access to health care in a timely fashion so these things do not occur? And even once you make health care available, there still becomes a challenge from a policy perspective. And once you make it available, how do you get someone to use it appropriately? And then when they're using health care appropriately, how do you make sure the providers are delivering health care to that particular individual in a manner in which they can receive and understand? So what are some of the crisis issues we find in health care? Women typically live longer. And that's not because men don't want to live longer, but the statistics tell us that women generally live longer. Men have higher death rates for the top 10 causes of death, more likely to be killed on the job. Women are more likely to visit the doctor. Addictions more likely kill men. Men face barriers to care. Women do also. Men of color typically have a lower socioeconomic status than white men. So we're going to talk a little bit about access to care, use of care, and factors motivating men to receive care. Because my thesis for many years has been, unless we address all of these issues, we really won't answer the question. So men compared to women, we talked about less likely to use health care, less likely to use preventative services. Most men have not had to get gynecologic examinations. You haven't had pap smears, breast exams their whole life. So if you tell a man when he's 40 or 45 or 50, he needs to have this intrusive prostate examination done, he'll say, nobody's sticking anything anywhere inside my body because I'm 50, 45, 50 years old. Nobody's stuck any finger anywhere in my body in my whole life, and you're not going to start now. And if you do end up being able to conduct a prostate examination on a man, the men may say to you, as statements I've heard before, now that you've examined my prostate, does that mean that I'm gay? And I say, no, it doesn't, with a straight face. But those are the kind of questions that we get. Once you tell a man now he needs routine healthcare screening that's invasive, then the guy says, I don't know that. I don't know what you're talking about. Men have not had that long-term relationship for preventative care. And we know that men like our Tarzan, who was flying to the air earlier, is going to be less likely to get in for routine care. Guys are going to use the emergency departments more likely for health care. More likely to be affected by wait time, which denies access. And also, true for all incomes, these statistics are true for all income levels and ethnicities. So, how do we access health care? Boys, typically in their early ages, are taken to the physicians or healthcare providers by their parents. Later, boys and men avoid primary care and still considerable pain and illness. We talk about sports physicals. Sports physicals, we say, are an excellent opportunity to do routine preventative health care for children, for teens, and for young adults, both for male and for females. But for a young male, what reason does a healthy young guy have to come into a physician's office at the age of 15 to, say, 25 years of age if he has no medical problems? But if he presents for a sports physical, we understand the unique opportunity that presents to be face-to-face with a person who has no problems but needs healthcare screening to get to the end of the road to participate in sports. ER visits, we said, most frequent source of care for men usually. Decreased self-referral for mental illnesses we find in men. Young minority men more likely to be referred through social service or the justice system, one English study showed. And we've seen in our practices over the years that for men who are involved in the criminal justice system have access to health care. But typically if a man leaves a penal institution or a correctional facility, they can no longer get access to health care if they don't have a disability, because as an adult male between the ages of, say, 21 to 64 years of age, that you don't have a disability, you don't have a job, you don't have access to health care. You have nowhere to go. So when you're incarcerated, you get access to care. But when you're released from incarceration, you don't have access to care. And so the last bullet on here, suspected result, higher rates of involuntary hospitalization for this group because they typically wait longer to access care. From the National Center on Health Statistics, a survey was done. Men are less likely to report recent contact with a provider, even when the services are free. They won't talk about it. Why won't a guy talk about the fact that he's been to a healthcare provider? Fewer annual visits, longer intervals between care, more reluctant to seek care. They use less medication, the access rates are lower, and African American males between the age of 15 and 24 have the lowest access rates of healthcare providers than any other group. So if you see a young man, an African American young male between 15 and 24, you have a golden opportunity with this group that has very little interaction with our healthcare institution. According to Ninger and Rich in 2000-2002, Young men, especially unlikely to receive reproductive health services, receive counseling and testing for HIV, STDs, are likely to receive other healthcare services, but routine primary care. Most of us in clinics are ill-equipped to deal with all of the issues surrounding this population. So, what are some of the barriers we think that men face in accessing healthcare? They believe that care and prevention are unnecessary. Just don't need it, don't have a problem, nothing's broken, why go ahead and fix it? And why ask a question and you'll tell me that something's wrong? Because as far as I know, everything is okay. So if you tell me something's wrong, then now something's wrong, but it could be wrong anyway. But if you don't tell me that it's wrong, then I won't know it's wrong because to me it's normal. And that may not make a lot of sense, but those are the arguments and some of the comments that we receive. You know, men typically need to project strength rather than need. They're taught to have a high tolerance for pain. We talked about financial barriers. There's the emotional denial. There's the shame associated with illness. There are communication issues, cultural competency, and then there's always racism about the provider's ability to communicate and to respect and to have that concern for the person who's receiving care. Galdis, 2005, the masculine pattern of independence and autonomy promotes denial of any need for help and possibly causes men to ignore symptoms or minor illnesses, stress, grief, and pain, or at least to suffer in silence. And as Dr. Ford mentioned earlier, we know that screening for depression in men, depression is very prevalent in men, but depression is undiagnosed in men because a man is not going to come and say, I'm not hungry, I'm not eating, I don't want to talk to my friends today, I'm no longer enjoying otherwise pleasurable activities. He's just going to disassociate, and he may become angry and violent, but he's not going to tell you the usual signs and symptoms of depression. So this suffering in silence becomes a real issue for men. Multiple survey findings. Men usually equated health to physical fitness. Help-seeking behavior is dictated by the social norm. Minor illnesses can be fought off. Guys often say they ignore symptoms, hoping that they'll go away. You have to be ill before you go see a doctor, according to 75% of this study participants. And if you perceive physical symptoms initially as something that will cure themselves, like a cold. How many men have you seen who go through life with a problem that lasts for years and years, and they say, well, it'll eventually go away. I don't have to worry about this now because it'll get better. I've been limping, I've had a knee that's had a problem for 20 years, but it's going to get better. I don't have to seek any care for this. So seeking expert advice was regarded as strange for men in general in the surveys that were studied. Economic barriers to care. 30% of respondents from Whitley and Rowe from 2005-2003, 30% of respondents aged 18 to 24 cite a lack of money as a reason for not seeing a doctor. Economic issues, a predominant reason African American men don't access health care. Lack of a job, lack of insurance, lack of co-payments were identified in the studies. Among Hispanic men, lost time from work, lost wages were a significant barrier for men accessing care. And also a lack of transportation. Minority men in their studies were much more likely to depend on public transportation to get to care. Racism and disrespect creates a barrier for health care access. The belief that will be a subject to a quality of care issues. Some individuals believe that they will get a reduced quality of care just because of their race. Disparities in treatment are inevitable because of economic factors in the client. Provider bias, whether they're conscious or unconscious, can be perceived by the person who's receiving the care. Cultural competency, language issues, the need for trained interpreters, especially poor educated persons, or specialized care. When I had my primary care practice, family medicine practice, we'd routinely have men you'd refer them to a specialist, and we'll use prostate cancer as an example, refer them to a urologist who specializes in cancer. The urologist recommends a course of treatment for their prostate cancer, but the man, and a woman may do it too, but as we're talking about men, the man may come back to his primary care provider who he has a relationship with, who he may see as his interpreter, quote unquote, and say, Doc, the specialist says he wants to do A, B, and C. What do you think? Should I listen to the specialist? And the primary care provider knows that you're not going to contradict a specialist that you referred your patient to because as a primary care provider, you trust your specialist. That's why you referred them to them. But your patient comes back to you for the go-ahead, for the approval. And they'll take time in their lives for a visit to come back to you to ask the question. Because that's how important it is for individuals, especially men, to have this interpreter, which may not be interpreting language issues, but they may just simply be interpreting the trust factor, and that what the specialist is telling this man can be accepted and translated as reliable and the best thing for that individual to do. Proposed mechanisms from Mansfield from 2005, proposed mechanisms of the barriers to affect seeking help, need for control and reliance, seeking help for problems with threatened autonomy, minimizing the problem, that it's not serious enough. Concrete barriers we've talked about, finances and transportation, lack of knowledge, and a lack of trust in healthcare providers. And Mansfield also reviewed that this emotional control, one's keeping one's own emotions under control and out of public view. The slide we had earlier about Abraham Lincoln saying, I stubbed my toe in the dark, but I can't cry and I won't scream, is a real issue for men from all segments of society. Masculinity beliefs, male socialization, variable influencing, help-seeking behavior, and health risk appraisal by men. No one wants to be seen as sick or weak. This masculinity creates efforts to conform to the socially prescribed male role based on what their social norms are. Every race has multiple subsections. Every society, every group in society have their own social norms. If you don't know what their norms are, you're not going to understand how they view the information you're providing for them or what you are encouraging them to do. Men not permitted to express themselves, their illnesses and their behavior. They may react differently to the system. They may react differently to health promotion messages. They may vary based on their age and their socioeconomic status and ethnic group, and theoretical relationship to risk-taking with our Tarzan we saw earlier flying through the air, but participating in these other risk-taking behaviors. James Talcott and his group from Massachusetts General Hospital looked at a study of 84 African American and 253 whites with newly diagnosed prostate cancer. What they found, African Americans were younger, more underlying illness, lower SES, while the level of knowledge among this group were comparable, if not better than the whites from this particular study. And African Americans were more often distrustful of physicians, but less likely to reject conventional Western medical treatments. They also found that African Americans reported having less access to health care. Talcott and his group said that their findings were more likely to be uninsured without secondary insurance, more likely to get routine care at a public medical clinic or emergency room, and these men were less likely to have regular physical examinations. And then finally, Talcott and his group from Massachusetts General Hospital found that African Americans were less likely to be seen by the same physician and follow up on a significant medical complaint. They were more likely to request prostate cancer screening tests than whites, meaning that the screening tests were not offered to them. They had to request the screening. The last one is physicians for whites were more likely to order the tests routinely. So when we talk about racism and we talk about cultural barriers, the patient that's sitting before you, are you going to offer them the same battery of tests and recommendations as you would anyone else that you see? And according to Talcott and this group at Massachusetts General Hospital, that this is not necessarily the case. That the African American men who were in this study more likely had to request prostate cancer screenings than the whites they were compared to. So, what do we do? How do we solve this issue? And I'll share with you a few slides about how we've attacked this issue in Prince George's County. We've decided back in 1995 to begin to look at what are the different many places that we interface with men. Where do we see men? Where do men access services? What other needs do men have? And we could partner with those other governmental agencies, community-based organizations. We could partner with those other groups to give men a reason to come into our office. And we would just, by the way, do a physical examination or provide some health-related services while they were accessing those issues. So addictions treatment, sports physicals, health education, birth control, counseling issues, dealing with societal issues with your children, examining their values and their morals. We developed a life management system many years ago that embraces and discusses all of these different issues with our men that come into our clinics. Number one, by engaging the men in all of these different aspects of their lives, we build a relationship and we build trust. And once we build relationship and trust, then we become a viable source of information for the men. And as we're trusted by them, then they're more likely to adhere to recommendations that we are providing. So from the next perspective, when we look at the importance of all of these issues, we are, number one, want to make sure that we don't leave any of them out. And as we address them, then we want to make sure that all of us in community, from our providers to family members to educational institutions, where guys go for recreation, government agencies, employers, all of these institutions and individuals have a role in men's health. And we know that the studies have shown that men who are quote unquote henpecked, or men who have spouses that are active in their lives, encouraging them to seek health care, are actually healthier. That if you have someone at home reminding you to go get your annual exam, someone reminding you to comply with the order you received to get an x-ray or a sonogram or get your prescription filled, then the guy is more likely to get it filled. So I believe to establish and promote men's health, that we have to be creative in healthcare to see how many other aspects of society we can involve to send a message and to create the partnerships for men's health issues. So in Prince George's County, we took a fragmented service. We performed some creative partnerships to benefit those individuals who were in need in our community. And in designing our center, we have a building in Suitland, Maryland. It's our new facility in Suitland that we have a men's health center. We also have some reentry services in that facility in our Suitland Health and Wellness Center. You know, we have our groups that we use. We discuss many psychosocial issues with our guys, but we also, for many years, and continue to address their health-related needs. We have some dedicated staff, and the gentleman on the right side, Bill Hall, has been our state kingpin there in making sure that everything runs smoothly for us and all the guys feel welcome and at home. Franklin Roosevelt said, "The success or failure of any government in the final analysis must be measured by the well-being of its citizens. Nothing can be more important to a state than its public health, and the state's paramount concern should be the health of its people." And I think we all agree with that statement. So we believe that from Prince George's County Health Department, and also from my experience as a physician, that typically the sky is truly the limit as it comes to men's health care. I saw a quote recently from President Obama from the beginning of March of this year that said that the problems that we are dealing with today are resulting from our lack of action from yesterday. So the problems that we are facing today are because of our lack of action yesterday. And we know that it's very true from a healthcare perspective. We know it's true also from many of the ills that men face in our society, that men have been an afterthought for many times for health-related issues. For insurance coverage, for public insurance, for state insurance, for federal insurance, men are often not included in the primary group of individuals to get access to care. So why are we surprised when men's health outcomes are much poorer than they are for women across the board? But I believe there's significant opportunities ahead for us to, provide service to men. And the 6 words that I have on the slide are caring, confident, and concerned. That if a man believes that you are caring for him, if you are confident that he can do it, and you are concerned about him, then you're much more likely to have an influence on the health of the male that is before you. We combine collaborative and creativity, and with that combination of all of the different resources that you may have available to you, all of the different individuals who may have an influence on the life of that individual, with those collaborations and a little creativity, then maybe we can have some inroads to have guys take advantage of our healthcare system, take advantage of those services that are preventative rather than seeking care at times only when they're in emergencies. And I want to thank you for listening and inviting me to participate in the lecture today. Thank you very much.
I want to thank both our presenters so much. And this is a time when we are taking questions, and both from the live audience and from those watching online. And one more reminder that you can email in questions to our email address at maphtc@jhsph.edu. That stands for Mid-Atlantic Public Health Training Center at Johns Hopkins School of Public Health. And what I'd like to do now is invite both of our presenters to come to the podium and take questions from our live audience. And I'll be down here looking for emails as well. So thank you.
Oh. I enjoyed the two presentations. Thank you very much for providing this important information. You provided the data about how men do not access services and all the reasons why they don't. So I'd like to address my question to Dr. Schell, who has tried to increase access to services. You've showed us your model. Do you have evidence that you've actually increased the utilization of services in PG County by men?
Yeah, we do. We don't have the evidence for on a societal level. Unfortunately, like many providers of care, we for many years had not focused on documenting how we've changed the course of healthcare for men in the county. Our services at Adams House routinely see about 3,000 men a year, which is a number that's high enough. We've often measured the effectiveness of our services by the partners that we provided services with. And so I'll give you an example. Child support enforcement, parole and probation, the family court center. So we've been effective in increasing the male's compliance with other orders outside of healthcare, but while they're in our presence, we provide them with routine care and screening and access to services. And so unfortunately, we had not over the years documented the number of men who have increased their screenings, but the men receive screening when they come in, but we've always focused on having men to comply in other areas outside of health, and while they're in our presence, we provide healthcare services for them.
So it doesn't sound like you're having difficulty getting them to come.
No.
So if you offer it, they will come.
They will come. And I think the challenge that we've had, what I did not address, we've had some creative issues in financing care and accessing care, and providing primary care and screening is pretty much a healthcare provider and a stethoscope. But when you have to do more like EKGs and other specific tests and some medications, those are some of the creativity and the difficulties that we've had over the years. But providing a point of access for men to come in and receive healthcare education. We have 100 men who come into our groups every Monday evening. We have women who also come into our center now. And so it's not a problem with men accessing. They just usually need a reason to tie in to come in. And once they're there, they pretty much are sold.
Thank you so much. I work in the city as a Spanish medical interpreter, and when you mentioned the theme of strength, it's really a bullseye theme. Most of our patients at the community health center, 85% are women and children. Many services are free. Men do not come because they're free. Every man that comes, I thank for coming. Thank you for coming. Gracias por venir a vernos. Since most of the staff in most health facilities are women, caring, it's even more important that whatever male, of whatever age, children included, feel the respect. That respect includes thank you and a smile. My job is very technical. Here's my question. You focused on strength, and we see that as a huge barrier and a huge motivational factor. What is your experience in tapping into another theme in addition to strength? I call the twin companion, the theme of protection, protector, which women see their role also as protectors of the family. How can the healthcare system appeal to the value of protector in men? And I primarily work with minorities, refugees, inner city folks. Something like linking men's health to the safety of the family, and saying something like, protect your family by caring for your health. Most of the men disregard their health because they don't value it, they value their family. And I guess what I'm wondering from a social health perspective and public health, how can we more combine creatively, as you had up visually, how can we more creatively combine the major themes of strength and protection linked into, gee, if you care for yourself as a man, you're a great man because you're protecting your family and you're helping to save your family. But we have limited success in our medical environment in that way.
Yeah, I think it's an excellent point. I think the critical thing that you mentioned, especially from your experience in the community health center, is embracing the men who come in. A lot of men like touch. They want to be hugged. They want someone to say, "How are you?" They want eye-to-eye contact. They want a handshake that's not rushed. They want to feel like they're welcome and that you're not, counting the seconds while they're in front of you. I think on the other side, when we talk about our partnerships with family, I think the women in the lives or the significant others in the lives of the men can do exactly the message that you're saying. I need you because you are my provider. And most people may not understand how important that simple, vocalizing how important a man is and how you depend on him to provide for you, his significant other, and for his family, will just stand him up, give him a sense of pride and self-esteem, and he'll go out and run through a brick wall. But you say, "Honey, when you hit the brick wall and you hurt yourself, come and let me know so we can go to the doctor." But you want him to know that he is valued. When a man feels like he's not valued and he is not needed, then he will shrink back and just fade away and say, "You know what, they won't be encouraged to do anything to take care of themselves." But I think the point you bring up about the value of promoting the importance of their role as providers, I think a lot of our programs that provide resources for women and children can undermine the role of the man as being the provider. And so in all of the services that we've done for years is to encourage the men to take their active role in providing, and that your children and your family need you. But many times in society, it's the exact opposite message. They don't need him. You can get access to this service or this program, so you don't have to depend on the guy to provide for you. And I think, like you're saying, it's the absolutely wrong message to give.
I have a question. Actually, I'm the technician here, but it relates to me. How do we find a primary care doctor that shows that compassion and all those criteria that you have been talking about? Because I found it to be difficult to find one. Collaborating with other people in my family, other males in my family, we've found that to be a struggle. So any suggestions on how to find that type of care?
I think it's an excellent question. I'll quite frankly say that a profitable medical model is counterintuitive to spending a lot of time with your patients. I mean, our system works by volume. You reduce the amount of money you pay to a provider and you increase their volume so then they can make a profit. So the more time your provider spends with you, the more you're going to cost them. But if you're capitated in a managed care organization, or if most people aren't paying, even if you're fee-for-service, but you're being paid by an insurance provider, then that healthcare worker or provider is only going to make a certain amount of money for all of the care they give to you. The shorter time they can give you that care, the more profitable it is, because the more people they can cram into a clinical session. The best way to figure that out is probably by word of mouth, talking to a lot of people, to take a healthcare provider and to take the business of medicine, to make that secondary, but then to make primary the developing the relationships, developing the trust, having the conversations, having the dialogue, giving your patients access to you when you're not rushed for time, when you are just discussing things about your kids and your family and your job and how you're feeling. And so that is a major concern. When I closed my private practice to go into the health department full time, I just shared a little quick story. I referred all my patients to another primary doc, a friend of mine, from Howard in College Park. And he called me the other day, which is why this was germane. And he said, Don, he said, I'm trying to see your patients, but if I don't spend enough time with them, they get upset with me. And he said, he said, thanks for sending me all these patients, but you've kind of had them for all these years, and you've been sitting there talking to them the whole time. And so now that they've back into the regular mainstream, some of my patients are very happy with the docs I refer them to. Most of them are all happy. But he said, they won't let them get out the room without having some kind of dialogue and exchange. And so I think it's trial and error. It's talking to a lot of people. It's taking that opportunity to go in for an initial visit, to just see how you feel, whether you feel accepted, if you feel like they're rushing you out the door. There could be other people in the office also to help create that sense of welcomeness and the warmness. It could be the nurse when you come in. It could be the receptionist. They could have other people. At Adams House, we have typically 4 or 5 individuals who interface with our patients, and so they may have an hour of contact time, sometimes over an hour, between all of our staff members who are seeing them. But I think that's an excellent question, but something that may have to take a little bit of research and going to see a lot of different doctors to see who you get along with.
We do have a question from our online audience, and this is from Manisha. She says, hello, I'm tuning in to the webcast with my colleagues from Workers' Health at the Pan American Health Organization. We're enjoying this meeting. We have a question for Dr. Schell. Does Adams House have an example of how occupational health services and/or the workplace have been used to reach men? Also, is there an example or best practice of how men's health has been promoted in the workplace?
Adams House has not done typically workplace wellness. We do have unions and other companies, corporations that we have worked with to provide them a healthy workforce. But once they're employed with those companies, they may continue to seek health care from Adams House. But we have not gone in typically to do a workplace health wellness initiative. Prince George's County government does have a model. We're working with the insurers for Prince George's County. We have 2 healthcare insurance companies, of which I won't mention their name, but we have 2 insurance providers who we're working with for workplace wellness. We're also working in the county with our Parks and Recreation Department to provide activities, opportunities for sports participation, team participation, so that the insurers are providing resources for our 6,000 employees in the county. We have a medical physician, Dr. Shirley Brown-Ornish, who helped me significantly with the presentation for today, but Dr. Brown-Ornish is charged with, as a physician, to oversee our 6,000 employees in the county, to work with our 2 primary insurance companies, to work with Parks and Recreation, to create opportunities for health and wellness among the employees. And so I don't know if that addresses.
Informative, and as a parent of a 12-year-old male, I'm very interested in men's health issues. And one of the topics you mentioned was depression, and it's a topic that is not often discussed. And I was wondering, what is the impact on depression within the PG County community as far as your health center, Adams House? How has that center impacted the PG County community and on the topic of depression?
Yeah, I'll say that the depression topic is an issue, is a tremendous issue for men. When you look at the perpetrators of violent crimes, mass shootings, which we hear too often in the news. You hear about a man who, murders suicide, kills himself, kills his wife and his children. You get the Columbine-like, occurrences. I think depression is something that touches every, socioeconomic status and every race in our country and around the world, and it's something that is typically masked or veiled in men. Whether or not it's domestic violence issue with, striking out, whether it's underachieving, whether it's not trusting. I think the depression issue in men is something you have to look for those other signs and symptoms that we talked about. Within Prince George's County, our work with men and with boys, I believe, with depression, was we haven't done a typical psychiatric or psychological medical model with depression. We have addictions and we have mental health centers within our health department. We have two. We have an intensive outpatient program for men, which Herbert works at, who's here in our audience today, and we also have a women's counseling center for adults and for children in our health department. So we have two intensive outpatient mental health programs. But for our normal population, quote unquote normal population, that have not been diagnosed with a mental health illness or depression, we have typically worked in Adams House to go into those areas where the men and boys are located. So we teach classes in the school system. We've taught classes to a group of, repeatedly over the years, to boys in the school systems. The schools will call us and say, we have a group of 20, 30 boys. We don't know what to do with them. We can't communicate with them very well. They're not doing very well. Can your group come in and work with these young men? That is a particular aspect of Adams House that I wish we could grow exponentially, that we could have one staff member stationed in every school to deal with these boys that aren't diagnosed with anything, the boys that may be underachieving, boys that may have been getting trouble with substance abuse or suspensions or getting poor grades, and the system can't figure out how to encourage or to motivate them. Because when you do the punitive telling how well you're doing in school by time that your rear end sits in the seat, and then if you can't do the seat time very well, then you remove them from participating in athletic activities or other sporting events, then if they weren't feeling well to begin with, and if they're not performing well because they're depressed, and you remove them from the very things that they like, then they're going to be even less likely to do well. So we work with Parks and Rec, we work with the school system, we have our youth groups that teens can come to, and so all of our government agencies and community-based groups in the county, in Prince George's, refer young boys and men to our program, because once they get to the point and figure out they don't know what to do with them and maybe they need some help, a lot of times those boys are depressed. And we don't tell them, you know what, I think you're depressed. We don't want to diagnose them or tell them that they're depressed. We want to, but give them the opportunity to express themselves, to give them the opportunity to explore what their problems are. And then a lot of times that helps them to better navigate whatever system we interface with them.
We do have another question online for Dr. Ford. What, if any, has the research shown can be the value of using community health workers to increase African American males' use of preventive health services and then use of medical care?
That's a really good question. This has been an area of research for quite some time. We have colleagues here who, for a long time, I'm talking about Martha Hill, Lee Bone, and David Levine, have studied the community health worker model as a strategy for controlling hypertension among African American males here in Baltimore. They've published quite a bit in this area. The community health worker model has been applied in different areas and has come under different names. Currently, there's a lot being talked about in terms of patient navigation, and Harold Freeman, a former colleague, I still stay in touch with him at Harlem Hospital, he developed the patient navigator program that is now famous throughout the United States as a strategy for getting women access to breast cancer screening, and really it used a community health worker model, lay health workers, and they were trained to actually deliver an intervention to promote breast screening among women. It was very effective in terms of early detection of breast cancer and the stage shift to early stages of breast cancer. And that model is being evaluated still across the nation in patient navigator research kinds of projects. And I showed data here from our CMS study, which uses a community health worker model. And we don't have the outcome data yet, but we think that this is a promising intervention. So there is a literature there that suggests that community health workers, promotoras, can in fact be effective to help deliver public health interventions. Now, one of the big questions is about cost effectiveness, and and some other areas that I'm not expert enough to talk about, cost utility and so forth. So I have to walk down the street and talk to some of my colleagues when we come to those questions. But in general, there is quite a bit of evidence that such interventions can help with African Americans and certainly with Hispanic, Latino populations and so forth. And I mean, the reason is that it makes it possible to deliver more culturally targeted or culturally specific interventions. It was interesting to hear the question earlier about talking to Hispanic men about the need to take care of their families. There is a literature evolving about the fact that there are different cultural orientations. Communalism is an important one in the Hispanic community, also in African Americans, but perhaps more so in decision-making, we know, in regard to breast cancer. That's documented in the literature. So I think what we need to do is to really learn more about what to do with particular populations, and the community health worker model provides the delivery method through people who are from the same community, who are indigenous to those communities, and perhaps will be more effective in delivering the culturally targeted interventions or tailored interventions.
Do we have any other questions? I want to thank you all for coming, and thank you once again to Dr. Schell and to Dr. Ford for a fantastic presentation. And I'd like to thank you for coming, and for everybody who's here in the live audience, if I could remind you to please fill out the evaluation forms on your way out. And a reminder that, again, on behalf of the Department of Health and Mental Hygiene and Johns Hopkins, we hope that you'll join us again next month on June 17th for looking at the impact of transportation on public health. Thank you.